web meeting on the single operator revolution. What is the mastering of polypectomy with Holdfinger? I'm really pleased and honored to be here today speaking about this new device that more than a device is a new concept to be applied in our daily practice. But first of all, let me thank Meditalia and all the friends from Meditalia for organizing such a deep and interesting appointment in order to help all the community of endoscopists and not only to share experience and to understand new devices and, as I told you, new concept. Let's start speaking about one of the most popular, the most common, the most used procedure that we perform daily in our endoscopy room, and this is the polypectomy. But before speaking about the polypectomy today, we need to come back to the history of polypectomy to better understand why and how. So polypectomy was born in 1973. This is an important date because it happened two very important things. One is that Dr. Anderoni was born. Okay, this maybe is not so important. The other important thing is that the first polypectomy was done. So more than 50 years ago, two guys understood that during a colonoscopy, they could be able to remove tissue from the colon, remove polyp from the colon. And this was done with efficacy and safety. Nowadays, polypectomy has a pivotal role in our practice. Why? Because it has been shown that if you remove a colorectal polyp, you reduce the incidence and the mortality of colorectal cancer. And this is clearly stated now also in the European guidelines. So this is a very, very crucial and important procedure to save life and is considered now as an essential skill for all the endoscopists who perform colonoscopy. So nowadays, if you perform colonoscopy, you cannot be unable to perform a proper polypectomy. But what is a polypectomy? Inside the concept of polypectomy, we have the technique that is very important. You choose the right technique in order to determine the success of your procedure, of your intervention, and the reduction of possible complications. Two, the procedure must have efficacy because your target, your goal is to remove the polyp entirely in order to reduce the risk of developing cancer. Safety, the procedure must be safe. You cannot act for the benefit of a patient doing something that is not safe, because this is not balanced. Last but not least, you have to bear in mind about recurrence, because there's no way you do a great effort if after 1 year the polyp recur. So basically, in our daily practice, we are like the lion in the ground. Every morning, a lion wakes up and he knows that he has to run fast. And this is basically the same situation in our condition. We need to fight with the polyp. We need to catch the polyp. We need to see, recognize, diagnose, and remove for the benefit of our patient, for the benefit of the community. So the strategy for polypectomy is important, and the strategy is based on some points. Very simple, very important. First of all, the size of the polyp. Small, medium, big, large. Second one, the side of the polyp. Rectum, sigmoid colon, left colon, right, and
I'm here.
sigmoid.
What you want?
Is everything okay? Because I can hear some.
You can continue, Andrea. It was
Okay, sorry about that. So very important to know the sides and the side in order to decide. Then the morphology of the polyp. Respective to the dimension, the morphology itself has a relevant role. And this is clearly stated also from the Paris classification. But there is also another characteristic proper of the polyp itself, that is the aspect of the surface and the vascular pattern. And this is pretty clear when you go to analyze with high resolution scope. The use of these two characteristics, morphology and the surface, allow you to better understand and to predict the possible risk of submucosal invasion. Can you understand how important is it in order to drive your decision, in order to drive your strategy? Last but not least, histology. Having a proper histology gives you the right instrument to choose the right follow-up for the patient. So, considering this characteristic, we can make an assessment of every polyp based on this consideration, on these factors. The size of the polyp, so smaller than 1 centimeter, between 1 and 2, more than 2, more than 4. The morphology, pedunculated, flat, or sessile. The side, left or right column, and the access, how easy is for the endoscopy to reach the polyp, to keep the position, and to address the polyp. For each of these factors, you are allowed to give points, and you can classify the level of difficulty of the polyp in this way. Between 4 and 5 points is level 1, 6 to 9 points level 2, between 10 and 12 level 3, and more than 12 level 4. What does it mean? Basically, the higher the level, the higher the difficulties of the technique for many different reasons. So in our practice, if you are not working in a very specialized center, if you are not a very expert endoscopist, you should start thinking that if you are above the level 2 or 3, you may have to send the patient either to another colleague or to another center because they are too complex. Which are the techniques of polypectomy? The first was the polypectomy that we were using for polyps less than 2 millimeters with the snare. You do the cold snare, you catch the polyp, and you cut. But then we have also the hot snare polypectomy, especially for bigger one. If you have a polyp that is higher than 2 centimeters in diameter, we classify the procedure as endoscopic mucosa resection. So polypectomy is considered for less than 2 centimeters, for more is EMR, endoscopic mucosal resection. And this can be as well cold, so without electrocautery. Nowadays, we have a nice snare that are dedicated to this, and Meditalia provide us with many different shape, very nice snare. Or you can do the hot EMR, either en bloc, so one piece, or piecemeal, especially if the lesion is bigger. So deciding of en bloc or piecemeal depends on size, shape, location, all the factors that we discussed before. Of course, the technique is changing year by year, is evolving year by year. And we can address the polyp with the conventional technique that rely on the injection of solution into the submucosa space in order to rise the mucosa and to keep the polyp away from the muscular layer in order to reduce the risk of complication. But in the recent years, a new technique called underwater is coming. And now we have robust data showing that it's safe with a good grade of efficacy. Basically, the underwater is based on the concept that you fill the lumen of the colon with water, and this allows the colon not to be distended as much as you have during air or CO2 insufflation. So the polyp is not so distended. Moreover, without distension, also the wall of the colon is a little bit, and this has been shown to be very effective in reducing complication and in gaining the good outcome. Last but not least, we have the advanced techniques. The advanced techniques are the techniques that we use for advanced condition, either bigger size or polyp that has a small invasion of the submucosal in some cases. And this is called the endoscopic submucosal dissection. And you can apply this to all the sides of the polyp. It allows you, if it has been done properly, the en bloc resection, and it can be applied also to the lesions that do not lift properly. The other advanced technique is the endoscopic full thickness resection that is, let's say, considered for specific condition, especially for recurrence. So when we think about polypectomy, we can make our strategy on the basis of the size. For diminutive that are less than 5 millimeters, we nowadays have the cold snare polypectomy, as well as for the small polyps. If you have a medium polyps that is considered between 10 and 19 millimeters, you can use the hot snare polypectomy or the piecemeal cold snare, depending on many factors. But for larger polyp, you need to do the EMR, either cold or hot, or to use the advanced technique. Last but not least, we have to think about the adverse events. The adverse events could be divided in two big families. Early complications that occurs during the procedure, delayed complication. Bleeding, perforation, and post-polypectomy syndrome are the most common early complications. Bleeding can be treated directly during the procedure by applying clips, by using a powder. There are many techniques. To be honest, nowadays, the bleeding during polypectomy should be considered not a complication itself, but as a part of the procedure, like during a surgical intervention. perforation. We rely now on the Sydney classification that classify the degree of perforation on the basis of the deep invasion of the wall. And you can recognize it even by endoscopic evaluation. Again, also in this condition, if you recognize, you can treat it properly, easily, quickly, safely. The last complication is the post-polypectomy syndrome that usually occurs at home, and the patient calls you mimicking a symptoms of perforation. But this is mainly due to the fact that during polypectomy, you gave, stress to the peritoneum, to the vessels, and you gave this, that is a symptoms that mimic a perforation. Late complications are the possible stricture. This is a stricture that we had after a circumferential ESD, or unfortunately the recurrence. Recurrence should not occur. If recurrence occurs, it means that your approach was not enough. So to be effective, the polypectomy must be successful. You should reach the lack of endoscopically visible remnant neoplastic tissue at the mucosectomy site. Second, you need to have a complete histological assessment of the specimen. So it's very important to send the specimen and to have the histological assessment done by the pathologist correctly. Third, you need to have no recurrence after 1 year. So what should we have to achieve the successful polypectomy? Adequate bowel preparation, very important, to see better and to reduce complication. Appropriate indication for the patient, this is obvious. Adequate setting, good position of the patient, having the right devices, having the right staff, proper sedation and analgesia. The patient doesn't have to suffer. The patient should be quiet in order to make your life better. Dedicated devices. Nowadays, you cannot address the polypectomy anymore with only one device, because there is no device that can say one fits all. There are different devices for different conditions. Training and expertise, very important. Training of you, but also of the nurse. And of course, you need to have the adequate referral network to address complex situations. So speaking about device, we have needles in order to inject. We have a snare in order to resect. The snare has different shape, different diameter. They can be, a single, multiple. And then, of course, devices to manage and prevent complication. So in between this, recently, a new single operator device control came up to us. And this is the Holdfinger. The Holdfinger is this simple ring that you can apply on your finger to reach a better control of your snare, to reach the single operator control of your snare. So this device gave us a new concept of the polypectomy. As I have underlined in the first part of the presentation, polypectomy is a crucial procedure for the benefit not only of the patient, for the benefit of the community. So, performing polypectomy properly, it's a must. Having something that will allow us to have a better, direct, single control on polypectomy, I think could add a lot of, let's say, awareness for this procedure. So this is a single operator controlled handling of the device. It's compatible with many endoscopy accessories. It's ergonomic. What does it mean? It has been built in the way that you can regulate on your personal finger. So this is another good thing of this device, that will not put you in the condition of adequate yourself to the device, but is the opposite, is the device that will fit your needs. And last but not least, is easy, ready to go, easily fitted on the tip of a single finger. So I want you to follow with me this video that is on Meditalia website.
Hello everybody.
This is Albeniz.
I have the pleasure to try today.
Is one
nice
of
innovation.
the most expert.
It's called the Holdfinger.
And it's showing
thought to have full control of
how
your
it
snare.
works.
Here we are using a cold snare from Meditalia, and the right way to use it is to see on the screen the tip of the snare. After we have to mount the Holdfinger. So there is like a fixture, like a clip. So we put the snare here in maybe 1 or 2 centimeters above the channel. So this is the right position. Okay, the Holdfinger.
So, as you can see, this is what happened during a standard colonoscopy. You see the polyp, you do the strategy, you need to do polypectomy, you put the snare you choose in the operative channel, and then you apply the Holdfinger on the snare.
Also have this part to adjust to the size of your finger. To me, I don't like to have a very tight position, but you can use it this way.
So this is the other thing, adjustable to your finger, adjustable to your needs.
This way you can control the tip of the snare with your hand. And it's thought to have full control, not only the tip of the snare, also to hold the snare, okay? So this is the position of the snare, and this is my forefinger inside the Holdfinger. So this way we can have control of the snare and the tip of the snare, okay?
So from this picture you can easily understand that now everything is in your hand. On the left hand you have the handle of the scope with the wheels. On the right one you have the snare not only to open and close, but also to regulate inserting or withdrawing from the channel. Moreover, with the torsion of the wrist, you can also apply a little bit of torsion on the snare that could allow you to better fit with the condition. Everything with one operator.
Okay, so here we have another small polyp, not so small than the previous one. We are underwater. We are taking again our device, our Holdfinger. Okay, so we can move our snare close better. So this is the tip of the snare. We open the snare gently. We position our snare in the right position.
Look at the wrist.
Check.
The wrist of the right
We press
hand.
with the whole finger. Now we close everything and we feel that we are ready. Look at that. Cut. It's perfect. So you can move the tip of the snare. You can open, close, repositioning, everything, you know? Everything by yourself. Now again, we clean the field. We aspirate the polyp. And now let's see how the scar is. We put more water on the scar.
Nice.
And it's a beautiful resection. So you can do it in a dry manner or in an underwater manner, whatever you want. So you can do for hot, for cold resections. Let's check. Everything is done.
So this is how it works. And now I'm going to show you during our daily practice what is our experience in Pavia. This is another video that was made by us during a standard day. We apply the Holdfinger directly on the snare. Doesn't matter what kind of snare, because the Holdfinger has been designed to fit with everything. Then you apply the Holdfinger. So as you saw, it's pretty easy. Put the snare in. When you are in position, you apply the Holdfinger, let's say 3 to 4 centimeters above the channel. You close, you adjust for your finger in, and that's it. And what is the application? Here is the application. So you can take the snare yourself. You will have the snare in your right hand. The left hand will use and control the scope. And with this, quickly, you can cut, you can aspirate, you can see, you can control. Then you can easily take the snare out, aspirate, and that's it. During your procedure, the assistant, the nurse, won't have the need to keep the snare for you because you will hold it. And so the nurse could be ready to watch the room, to prepare the histology, to help you with other things. I think this is another good point. So this was the one that we have seen. Okay. And this is what Dr. Laura Rovedatti says to Holdfinger. She is one of the most experienced in our unit, and I asked her to give an impression.
Hi everyone, I'm Laura Rovedatti from Pavia. I've been using Holdfinger for several polypectomies, and the main advantage of this device is the full control of the snare during resection. In my experience, especially during cold snare resections and piecemeal EMR. The more you use it, the more you get used to it. I'm looking forward to see future applications and how it has been used in other centers.
So this is another good point that Laura raised. The more you use it, the more you get used to it. This is a new concept. We need to change a little bit our mind in order to be familiar with this device, but also to change a little bit the organization of our room, showing, explaining the possible advantage of this single operator approach.
Hi everyone.
So, other advantage. Look at this. This is another polypectomy that we are doing after a first one. And as you can see, the Holdfinger was left on the snare. So we know already that it's in the right position. We don't have to take it out. And this will allow us a better and quicker approach. While Laura is positioning, the nurse behind her is preparing other things, the polytrap or the stuff. Laura doesn't have to wait for the nurse to be on the handle of the snare. Of course, she can ask the nurse to take the scope and to fix the scope to make the scope steady. But in the meantime, she can easily control with a small adjustment, not only of the opening of the snare, but also of the advancing of the snare. Quickly removal and aspirate. So this, I think, is a good advantage. But of course, we can be also using this device in other more complex procedure. This has been shown pretty clearly by Yamamoto in Malta this year, and this has been doubled in Pavia as well. So during, and this is an upper GI ESD, we were using it for marking. And as you may recognize, in this case, the Holdfinger has been placed on the left hand, not to hold the snare, but to use it for the knife. So the next step, my friends, could be this.
Vai leggera più avanti, brava. Io lo apro piano piano, mentre apro vengo indietro. Poi vado giù, vedi? Giro così. Faccio così. Holdfinger! Na 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 na, with a high touch.
So this was just for laugh, but not only, also to show you how easy it is, how familiar you can be with. You saw a lot of people in the room, but only one was moving, was working. That was me, under complete control. Personally, I want to draw a similitude between this single operator device and other single operator device. I come from the biliopancreatic endoscopy area, and 12 years ago, we started using single operator devices for cannulation. At the beginning was a little bit not scaring, but strange for us. But in few exam, we realized that that could be a game changer in our daily practice. Nowadays, I perform my ERCP mainly as a single operator approach. So the final remarks could be that when you have a polyp, you need to optimize the polyp resection for a better results in every daily practice. Why is that? Because we show that polypectomy is a critical moment in the life of the patient, is a critical moment in the environmental condition of our endoscopy. Second thing, the Holdfinger is a new device that probably could change the concept of polypectomy, bringing it from a procedure that needs to be done by different person to a procedure that could be done under single operator control, probably giving us a better awareness, a better sensibility, and make the resection more effective. So I thank you very much for your attention, and I am ready to hear from you or to know if there are other ideas, questions, or if any one of you want to share the experience. Thank you.
Okay, thanks, Andrea. The presentation was great. So maybe here there is also Riccardo. So if anyone have some questions to do to Professor Anderloni, it's free to ask.
Yeah, I just want to thank you, Andrea, for another masterclass about this. Also, you didn't mention your experience regarding ESG guidelines, because nowadays everyone here has so many endoscopies in the room. We know ESG guidelines should be that the endoscopist must perform polypectomies or having the control of SNES, but I know that maybe it's not that real already. Daily routine, it doesn't happen that much. I guess that the Holdfinger might be a good help to this. I don't know if you want to share your experience or other endoscopists here, what they think.
Well, Riccardo, of course, this is a very, very important point. I wanted to highlight the importance of a proper polypectomy. The importance of a proper polypectomy stays on the fact that the polypectomy nowadays is a critical point for the life of our patients. We need to understand this because we perform this procedure many times in a day, but we need to be focused in that time because in the moment we are going to remove the polyp, we are going to reduce the risk of cancer. And this is such a power that you have to perform a polypectomy in the best possible way. So the ESG guidelines clearly stated how important is it and how important is that each colonoscopist must perform the proper colonoscopy. Now, Riccardo, I want to ask you, when I go to do polypectomy, I usually work in my unit. So I had the time to build a nice group, a nice team. My nurses knows exactly what to do, how to do, when to do. But even in my team, there are different nurses and there are different operators. Not all the nurses works the same way, not all the operator works the same way. So this can be even higher when I move to other hospitals. As you know, nowadays, many doctors work in different hospitals, not only for a private, because of the new organization of the National Health Service. And this is not only in Italy. So whenever I move, I have to rely on different, how can I say, colleagues, on different teams. And I don't know which is the real level of the team. So having the possibility of controlling the snare for me could be an added value. First of all, one of the things that I like of these devices, let's say of this device and of other devices with this characteristic, is that it doesn't put me in the condition of a point of no return. This is very important, Riccardo, because I can use it in a relaxed way. If I see that I have some problem, which really I don't know what kind of problem, but I'm telling in order to make everybody more relaxed, I can switch to the previous technique. And again, I can come back. So this is something very important. This is not the device that put me in one way. This is me that can choose the best solution. Second, when you have to cut, there are plenty of critical moments. When to cut, definitely. How far to cut, especially during the hot approach. As you may know, the hot polypectomy, should add the power of the cutting with the power of the coutering. So putting this together could be very difficult, especially if it's done by two different persons. So having the full control allow me also to adjust the pressure that I give to the snare. Look, Riccardo, I was telling before, I do paragon comparison also with the biliopancreatic world. There is one procedure that asks you to do a polypectomy in biliopancreatic endoscopy. That is the papillectomy, what is called ampulectomy. Well, those are usually lesions of 2-3 centimeters that at the beginning they are not cutting because you need to wait for the current to pass properly. But if you don't have an experienced nurse moving this, you can be in trouble. You cannot understand properly what is happening. And this is not a very good sensation. So sometimes I ask to the nurse to give me the snare in order to feel. This could be bring also to colonoscopy. So having the possibility to control, especially in bigger lesion, could even add more safety, I suppose. But definitely the 2 points are this: giving the control during the cutting and the passage of the current, but also giving the control with the wrist torsion. If you can take a look of this movement, you should imagine me moving the snare easily thanks to the Holdfinger in this way. And the snare will adapt itself to the wall of the colon and to the shape of the polyp.
Okay, Andrea, I don't know if you can see the question in our form. There is 2 questions from Harmeyer of Cobra Medical. Can you read it, or maybe I read it to you?
So yes, I can read.
Okay.
What ongoing studies are currently performed to create clinical evidence for better polypectomy outcomes? And what do you say to the nurse that might feel redundant during the procedure? I like very much this second question, so I will start from this. This is something that I didn't touch during the presentation because I left it for the discussion. This is a very important point. The nurses are the heart of endoscopy. Remember, without the nurses, you cannot go anywhere. It's very important to build the awareness of the importance of polypectomy and to make not only the nurses, but all around you understand that this is not something in order to still work and to do only on my own. This is something to give the best option to the patients. The nurses won't be redundant at all, also because nowadays we are lacking of nurses. So the nurse should not be afraid, should be happy, because at that time she will have more time to prepare the specimen, to prepare the report, to put the specimen in the right position, to write something on the nurse board. So this is something that won't exclude the nurse. This is something that will bring the nurse to do a better job, to do a proper job. That will put the nurse in the idea of taking care of many other things. So this is very, very important. The second thing is, yes, there are studies that we are conducting with Meditalia, with some centers at the moment, and probably we will perform more prospective studies, especially to see also the learning curve. Because what we are realizing is that to enter with this new concept, you need also a little bit of open mind. And like all the stuff that comes for the first time, you may need few more seconds in order to get familiar. But as Laura Rovedati said, the more you use it, the more you get used to it. And this is our philosophy nowadays in our center. We have our Holdfingers in all the rooms. You can take it, you can use it. And if you need to change, no problem. But when it's on the snare, you can leave it and you will find always the Holdfinger in the right position, ready to help.
Okay, I'm seeing maybe Mr. Ahmed Gahin is writing something.
Yes, let's wait. So what do you think, Giulio?
I think you was perfect as usual. The presentation was great, and you to put the point, it's very important about the nurses. So I remember when I was in your in Pavia, we were trying. I remember your colleague, the nurses, let's say, is like driving and asked to your colleague to change the brake. It was funny and easy, because it's very important to understand the important to have the to feel the sensation of the cut, for example. So basically, it's very important to understand that the nurse is, as you said, really important in the hospital, in the room. But there are a lot of tasks that have been made by the nurse and something that has to be made by the doctors. So is this the point that I want to underline?
Yeah. Thank you very much, and thank you to Ahmed, because he's drawing another important point. The question is, I think we need more training to perform the complex movement during polypectomy. For example, pushing during snare closure or rotating while withdrawing or capture the polyp. Or even watch some videos to imitate the guest. Okay, so I think this is another crucial point, because Ahmed, you touched the most important point. Having the single operator control allows you to do exactly what you have said. That means while I'm closing the snare with the Holdfinger, I can also advance or withdraw the snare. This is something that is very difficult to do when you are speaking with the nurse, because the nurse will start closing, but maybe you think she's not starting. Maybe you have to push to withdraw the snare, but it's very difficult to be on the same wavelength. Whereas with this, I think that while I'm closing, I am going towards the polyp, or I am moving like this. Moreover, understanding that while you are doing this, you can do also this. This is something. This is something that will add a lot, because this will give the torsion of the snare that you cannot easily reach without such a device. Because when we do polypectomy, let's say with the standard approach, we can open the snare, close the snare, we can go further or withdraw, but we cannot allow the snare to do this. With the Holdfinger, since it's fixed to the snare itself, I will have the possibility of giving just a small degree of torsion, but small sometimes is more than enough to reach the success. So probably Ahmed gave us a nice idea, preparing video like the one of Albanians and like the one we saw from Pavia, maybe showing also specific moment for specific movement, specific moment for specific movement. Yes, yes, yes. Subconscious training. Oh, we are addressing a very nice thought now, and this is exactly what we were saying. The more you use it, the more you get to use it. In a more elegant way, the subconscious training. Yes, I fully agree, Ahmed.
I also want to say to everyone that we are also producing more videos. We are also studying some 3D videos in order to understand you better the movement, of course, of the hand with the old fingers put on. So we're trying to enlarge of production, so in order to let you understand better everything.
Yeah, basically to conclude, in our experience, I can tell you that one of the most important things is to start using, to keep your mind free, start using, start trying the procedures, start trying the movement, and find your best way of using it. Because the beauty of this device is that will allow you to be used the way you want. Someone prefer to put in the mignolo, we say in Italy. Some other in this. So doesn't make a big difference as long as you feel confident. The more you use it, the more you get used to it.
Okay, if there is any other questions, or we can of course thank Andrea again. Maybe Ahmed is writing. Ahmed is on point.
Ahmed is very active.
Okay, no, you just thanked us. So thanks to all of you, and especially to Andrea for this wonderful presentation. And we are here to answer by email to any information, and let's try the product and more. Thank you, Andrea.
Look, thanks to you, thanks to Meditalia for all the effort you daily produce in order to allow a better life for us and for our patients, because I think that those ideas, this way also of sharing is very, very important for us. But thank you also for pushing us in order to find the best way to use the devices and in order to, again, share the experience between the experts. I think this initiative, like the one we had today, is very useful. For me, it has been much useful that I because while preparing the slide, I was speaking with my team. The team was giving me some feedback. So very important, Giulio, you saw how we work in Pavia. We had the possibility of make the procedure done by many doctors. And we got a lot of feedback from different doctors. And this is very, very important.
I think it's the best way. Yeah.
And the other important thing, especially for people working in Meditalia, is to understand that behind everything, there is the patient. Behind everything, there is the community. So giving the possibility of working better will give a lot of benefit to the community. That's why I wanted to stress a little bit about the history of polypectomy and the importance of polypectomy. Because if you know this, you better know the power of your device.
Thank you, Andrea. It's great. I am very happy for this thing. So as Ricardo was writing, of course, we can see the UH week in a couple of weeks, so we can try on your really hand on the operator. So thanks to everything, and bye. Grazie, Andrea.
Thank you very much. Looking forward to see you in Berlin, and of course,